Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Hey, welcome aboard, and thank you so much for being a part of our program. Probably the most educational and most important program about vascular surgery anywhere, but particularly here in Hawaii, Vein Clinics of Hawaii, on 4 islands, Kauai, Maui, the big island here on Oahu. Dr. Juliff is I want to say he's the Grand Mufti, but he's the medical director, and he calls all the shots. And one thing that, we do on this program is we cover the ins and outs, and you can go to veinclinicsofhawaii.com and select previous shows and listen to them and get podcasts and get a lot of good information. Today, and we talk about this a lot, today we're going to talk about pregnancy and the treatment of vein disorders during pregnancy. And you're going to find out the ins and outs of this entire thing. Now, guys, I don't want this to be a cue for you to grab a couple cold ones and go out in the garage and tinker around while mom listens to the show. I think it's very, very important. And it even goes further for those of you that are parents and grandparents of gals that get hapa or pregnant. I learned when we first started doing this show from Dr. Juliff that there are very high probability that there's going to be something happening in your venous system during pregnancy. And that means good news for me because I'm not going to get pregnant. But I certainly have people around me who are. And, Doc, I think it's a great idea to provide this information. And I guess it's because there's so many changes that go on in a female's body. Are they more likely to develop venous insufficiency while being pregnant? And if so, why?
Well, I think that the bottom line there is, pregnancy is a risk factor. Multiple pregnancies would be a risk factor for developing venous insufficiency over the course of your life. And there are specific things that happen during pregnancy. The hormonal milieu of the body kind of leads to relaxation of various tissues, and veins are one of them. They become a little more relaxed. They're more likely to dilate. Yep. Another thing that happens is that the blood volume of the lady increases significantly, so there's more blood sloshing around inside those veins.
I never thought about that, but of course, you need extra blood for that little baby.
Yeah. And then as the pregnancy goes on, the uterus is getting larger and larger, and there's a bunch of big veins in the pelvis that uterus is going to be laying on, and it's going to have an effect. But there's a bunch of stuff as it relates to venous disease in general that happens during pregnancy, and we recently talked about that. We recently talked about how likely is someone to develop varicose veins. If they do, should it be treated? Or if they after the pregnancy, are they going to go away? Et cetera, et cetera. Today, I wanted to talk a little bit more about deep venous thrombosis, DVT, blood clot, because women who are pregnant are at a little higher risk of developing DVT just by virtue of being pregnant.
Yeah, I know we talked about that off the air at different times, and it's very important for people to know that there are so many things that may want you not to think about things like travel and other things. We've already talked about that in the later stages of pregnancy anyway. But you've also said that if you've got the possibility of having a deep VT somewhere, travel shouldn't be on your list.
Well, travel is going to be an additional risk factor for developing a DVT if you are pregnant. That's why I'm always surprised when I see so many women taking long plane rides, and they're like 7-8 months pregnant. But women in general, when they are pregnant, they are 5 times more likely to develop a DVT than when they're not.
Wow, that is a statistical thing to pay attention to.
That's huge. That's huge. Now, pregnancy in and of itself is what we would consider something that we call a hypercoagulable state.
I'm glad that you say that, not me. That's a tongue twister.
Sometimes I can't say it. But basically, that just means that the blood is more likely to clot. Some people have genetic abnormalities with their clotting system, and they are more likely to clot and form DVT. But that's a natural state in when someone is pregnant. Now, why is that? Well, from an evolutionary standpoint, it probably has to do with the fact that bleeding is a potential complication of pregnancy and in birth. So, very likely the going in the opposite direction and trying to protect the pregnant woman from bleeding was beneficial over a long period of time. Actually, bleeding during childbirth can cause maternal fatality. Sure. But actually, in this country, in the United States, as well as in other developed countries, the morbidity and potential mortality comes more so with thrombosis and blood clots that then embolize and go to the lungs or whatever.
Has there been, or is there instructions or precautions or procedural things that you should do or know about? And I would guess your OBGYN or your prenatal person is going to be able to advise you to be more, maybe increase the awareness about symptoms real early.
Symptoms, yes, sure, definitely symptoms. But, taking the precautionary measures, again, going back to compression and elevation and avoiding those situations where you might be more likely to develop a DVT, like getting on a 10-hour plane ride. And the interesting thing about this propensity to clot goes on actually even a little after the delivery of the baby. So even after pregnancy is about a 6-week period where women are hypercoagulable. With respect to your question from just before, what should you do? Well, you should do things that we've talked about, compression, etc. But I think more importantly, you have to be aware of other things that may contribute to developing a DVT if you're pregnant and you have other things going on.
Yeah, and I know there's a list coming up on that because Doc loves his list. But I can tell you another thing, and I think this is incredibly important because it's common to hear, and everybody said, "Oh, my aching back," and maybe sometimes the discomfort or the pain or the symptom or what's going on may not be a back at all. It might be something else.
Sure.
So, there are some people that can handle a pregnancy and physically do just about everything, but there are some people that day one have mobility problems.
Yeah.
But what I'm getting at is it seems to me that some of the symptoms you get when you're not pregnant about veins and issues may be mistaken for, it's just because I'm heavier that my back hurts, or maybe there's something else going on in there.
Yeah.
I know you don't do a lot of treatment, but you can certainly do a lot of examination, I would imagine, sometimes. If there's a symptom that needs looking at.
Oh, yeah. We periodically... We have, pregnant patients come in with complaints that are concerning, and we do, ultrasound or whatever studies we need to kind of figure it out. But, with respect to other things that may add to the risk, and we have to be aware of these things because at some point you might want to, it doesn't happen very often, but you may want to treat that person prophylactically to protect them from developing a blood clot if their risk is too high. So, if you're pregnant and you know that you also, in addition to that, have what we call an inherited clotting disorder. Now, many people know that they have it. It's not a very, generally common known kind of state, but, there's genetically determined, and that's why we call it inherited abnormalities in the clotting system that make some people more likely to clot. Now, when a lady is not pregnant and they have a clotting disorder, you may not treat it. You just need to be aware of it. Yeah. But if that woman has that disorder and is pregnant, then that's a very important feature. We need to know that. Being over the age of 35.
Mm-hmm. You know what? I'm glad you brought that up because I got to ask a question on that. And that is, we see so often now in our modern world, in the U.S. anyway, a lot of times people either continue their education or want to get a real good foothold in their careers before they have children. And it is not uncommon now for women in their late 30s and even early 40s to have babies and older.
Right.
But you said with that comes... That's another risk.
That is a risk factor. Yeah. Okay. So if you're over the age of 35 and you're pregnant, then your likelihood of developing a blood clot is even higher.
Yeah.
Than
in other words, 5 to 1. It might be worse.
Yeah. So history of DVT. If a lady had a deep vein thrombosis at some point prior in her life when she wasn't pregnant, then that puts her in a little higher risk. Immobility, gestational diabetes, postpartum infection, all of these things are things that may contribute to making the risk concerning. As you have more and more of these risk factors, the likelihood of you developing a DVT may become to the point where it might be advisable for you to be treated prophylactically. Again, that doesn't happen very often, but this is the information that women need to know as they're going through these things.
Another question that also came up was when we talked about obesity, and obese ladies get pregnant too, just like unobese. It is said that some don't gain a lot of weight because they're already very, very large.
Right.
But are there additional risks if you have a history and you are obese? That number must be even scarier for you.
Yes, that's exactly it. Yeah, obesity is another one of those things that's going to increase the risk even more than it's at just by virtue of you being pregnant.
Okay.
So why are pregnant women so-called hypercoagulable? Well, there's something called Virchow's triad. And Virchow was a doctor, in the, I think, 20th century. And he was German. He was actually a pathologist, and he looked at clotting, and I think he was the first one to sort of define pulmonary embolism.
That's pretty fascinating because that was a while ago. Right?
That was a while back. Yeah. So he found that the likelihood of developing blood clot has to do with three things. Venous stasis, which means the blood is not moving the way that it should, is not moving as quickly
Too slowly,
yeah.
Okay. I know. I got a question coming up on that in a bit. Go ahead.
Something that we call endothelial damage. So the endothelium is just the inner lining of a vein, and if that inner lining becomes damaged, then it's more likely, just in general, I'm talking about everybody now, not just pregnancy, but if there's damage to the inner lining of the vein, then it's more likely to develop a blood clot. And then obviously if there is some situation that is causing hypercoagulability, obviously the likelihood is going to go up with respect to developing DVT. So being pregnant brings on basically all three of those things. This guy Virchow came up with three items that you have to be concerned about with respect to developing DVT. So flow is decreased during pregnancy through veins. And why is that? Well, we mentioned at the beginning of the show, the hormonal changes that occur, the relaxation of the vein wall is really what's happening, and because the vein is dilating, obviously the amount of blood going through that vein is going to move more slowly.
Okay, now there's a whole bunch of stuff that comes up about that. one of the things that we've learned in previous shows, and guys, I hope you're still there. Once you see what these gals are going through to do, to provide us with our children and our grandchildren, great grandchildren, all that stuff, it's pretty risky business. There's lots of things lurking out here. That's why, thank goodness, now there's things where you can, properly prepare. Particularly, Doc, if you are a little bit older than the previous birthers, and when I'm talking about in your 30s or 40s, you must have to go through a pretty good. Okay, if I'm going to do this, I'm at risk for certain things that I wouldn't have been 10 years ago, so I got to take better care of myself during pregnancy.
Well, not only take care of myself, but also
take care of the baby.
Be aware of these things.
Yeah.
I mean, there's a whole host. There's a bunch of information out there that ladies, if they're thinking about becoming pregnant and they're above that age of 35, they probably need to look into. Well, what are the additional risks that I'm going to be assuming by having another child at the age of 38, 40, et cetera?
That's why when you said earlier, multiple pregnancies,
right,
keep increasing the risk.
Sure. Yeah. So, with respect to flow, the studies have been done looking at flow within the veins in the legs, and the flow velocity can diminish by 50%.
Whoa.
At the 25-week mark. Now, 25 weeks into a pregnancy is not all that much. Women, when they're at that point, they're just barely showing off.
Sure,
but even by then, the flow velocities have diminished 50%. So that just means that there's more stasis and more likelihood of blood clotting.
Do you then go to a prescribed program of blood thinning or something to speed up that? Is it necessary to do that?
Well, not most of the time. We're going to touch on that here in a little bit. But that is always the question. And I think that's, in going through all of this risk stuff, that's the bottom line. At what point are you going to prescribe for a woman if she's pregnant? Does she need some anticoagulation prophylactically to get her through that pregnancy? Now, 99.99% of the time, the answer is no. But there are very specific situations where you might. Also, with respect to flow, we talked again a little earlier about the fact that as the uterus is getting bigger, it's obstructing flow in those veins within the pelvis.
Is it actually smashing them down a little bit?
Yeah. It's like laying on these veins, and so that's causing slowing of the of all of the venous flow, downstream, which is all of the veins in the legs, and that's typically where DVT occurs. So the other interesting thing with respect to that is most DVT during pregnancy happens in the left leg.
Wow.
Yeah.
Yeah, wow.
And that's because of the fact that because of the uterus, falling or enlarging and impinging on, the venous structures. Because the way the anatomy is, it's more likely to impinge on the left-sided veins and consequently diminish the flow and lead to DVT. So then there's this the concept of endothelial damage, damaging the inner lining, and that's something also that can happen during pregnancy. The pelvic veins can become traumatized to one extent or another just in the delivery process. The inner lining of the veins can actually be damaged because of the increased pressure on those veins. And pelvic vein thrombosis is pretty uncommon, except in this group of people, pregnancy.
It's actually fascinating, isn't it? In other words, gals, and I guess now, thank goodness, because of the way technology has gone, sometimes you'll see an ad on TV talking about a medication saying, now, if you're going to become pregnant or might become pregnant, don't take this medicine. So there are a lot of things that your OBGYN and your prenatal guys or gals are going to be sort of informing you as quickly as you can absorb them, really, because doesn't it have to start this different lifestyle very early in the pregnancy.
Yeah,
to eliminate risk.
And
minimize it,
and and the risk of DVT during pregnancy is equal during all 3 trimesters.
Oh my! Yeah.
So you're right. It's something that you need to start thinking about very early on. It's not like as the pregnancy goes on, your risk is increasing, so you don't have to worry about it as much early on. It's really something that you need to be thinking about throughout the entire pregnancy. So anyway, with respect to the hypercoagulability, that's even harder to say.
Actually, I'm going to put you a high mark on the chart because that's 2 times better than I would have in my best day.
So, there's something called the coagulation cascade, and that has to do with the normal function of blood clotting. I mean,
you have to explain the benefits or the reason why coagulation is necessary.
Yeah, well, I mean, any injury,
is it
surgery,
stop?
Yeah. And so, I mean, the ability for our blood to clot is extremely important to our survival, obviously. But on the other hand, if it goes too far, that can be a problem too. But there's a variety of different proteins in our blood, and they're called clotting factors. And there are factors, there are cofactors, there are other things that kind of go into it. But there's a bunch of proteins in our blood that are not active until they need to be, and then they kind of progress to developing a blood clot. There's a particular blood cell called a platelet. And a platelet is very important in the normal clotting process.
By the way, those of you that are donors, and I think the local blood bank here needs 200 donors a day, is they break it down into 3 categories, right? And platelets is one of the important ones.
Sure.
And is it sometimes indicative? I know this is a field of what you do, but is it sometimes indicated rather that somebody needs some of that?
Platelets?
So somebody platelets.
Oh, yeah.
A pregnant person specifically.
Probably not.
Yeah, that's what I thought.
But you're right. I mean, platelets is one of the things that we transfuse in certain situations. But typically, it's people that have too few platelets, and often they have a bleeding problem because they lack platelets. But so on the other side of this clotting cascade is a group of proteins that act as sort of natural anticoagulants. They work against the clotting cascade because if all you had were molecules in your blood, these clotting factors, and nothing kind of keeping those in check, then the minute you started bleeding and started to develop a blood clot, your whole blood system would clot off.
Yeah, and gang, that's why doing this program is so fascinating. And I want you to visit VeinClinicsOfHawaii.com and see this and other shows that you can link to. But more importantly, see the length and the breadth and the scope of what they do. Because one thing that has been very clear since we started doing the show, and the show is coming up rapidly on its first anniversary, is that it is generally discouraged to have much treatment, if any, vascular treatment while you are pregnant. And I guess another reminder of that is that there are a whole lot of things going on in the body that probably don't need too much interference with, because there's lots of little things going on.
Oh, yeah. Yeah, we try tremendously not to do anything to pregnant women, and we try to give them as few drugs as we possibly can, and we'll talk about that in just a second. But so there's this balance between the clotting factors that want to clot your blood, and then other things that are protecting you against overclotting, and in pregnancy, basically, that balance is shifted more toward the clotting side.
Okay.
And that just has to do with the enhanced activity, I guess, is what you'd say, of the clotting factors. Again, it's probably a hormonal response to pregnancy. But again, it's kind of, again, from a theoretic standpoint, it's getting a woman ready for the hemostatic challenge of delivering a baby, because bleeding can happen, and her body is trying to protect her against that.
Yeah, incidentally, that's another thing. Someone's always asked this, and even though it's a slight departure from what our program today is, and that, of course, if you're just joining us, is the treatment of DVT, deep vein thrombosis, during pregnancy, is that many, many times there are other things going on that are, really, really have a red flag go up, and so what we got to make sure of, and I actually missed my train of thought because I was hoping to find out if during this time, this pregnancy, if that there are other things. We already know you shouldn't smoke. We already know you shouldn't drink. But, there are probably some other medications and things that if you have a habit of doing, you shouldn't be.
Oh, yeah. There's a whole host. And like I said, in general, I mean, there's very few medications that I think most OB-GYNs feel are safe to take during pregnancy. Otherwise, you really need to do without. Yeah. And that kind of brings us to the next topic, and that is, should we prophylactically anticoagulate all pregnant women? Is the risk that high that we should give them a medication to thin the blood? Well, the short answer to that obviously is no. And why is that? Well, because of just the point that you were getting at a minute ago, there are tremendous amount of potential complications to not only blood thinners, but any medication.
Here's something that people maybe don't think of, especially you guys, is loss of blood in pregnancy. I mean, outside of maybe a C-section, is there that much going on that exposes blood? You hear this wonderful thing that happens. Well, her water broke, and we got her to the hospital just on time. All of this stuff came out of her, and here's the baby, and everybody's doing fine.
Yeah.
There are other things, right?
Sure.
And I mean, every now and again, there must be maybe pretty hard to stop bleeding.
Well, the placenta,
sure,
which is attached to the inner lining of the uterus. There can be problems with that can create tremendous amounts of bleeding, and that's the thing that can lead to maternal mortality during the delivery process. But there's all sorts of reasons why that might happen.
We are better off in our society about that today. Obviously, because this is something that I don't want to say it's expected, but it's certainly planned for.
Mm-hmm. Yeah.
So you got the right folks standing by for just in case.
Yeah, sure. Yeah. So so for instance, what are some of the complications of blood thinners? Well, there's a medication called Coumadin, which many people have heard of, and Coumadin, if you use it during the first trimester, the risk of miscarriage is about 50%.
Wow.
So obviously you don't want to take Coumadin.
For those that don't know what that is that one of the many blood thinners?
Yeah,
Coumadin?
well, I mentioned Coumadin. It's also, the generic term is warfarin.
Yeah, warfarin. Yeah,
and I mentioned that only because it was our primary anticoagulant for many, many years. And it's, the thing that they call rat poison.
Yeah.
And when it's used safely, obviously it was a very, very good drug for many years, but we've got, other anticoagulants that are a little safer now. But I just mentioned that because before we had these other alternative medications, I mean, Coumadin would have been the medication that you may have thought about giving to a pregnant woman if the necessity was there. But 50% risk of miscarriage is a little too high. That risk is way up there. Now, with Coumadin, there's a 30% risk of a baby having a congenital abnormality if it's taken during the first trimester of pregnancy. So that's another major risk. And it crosses the placenta. So it can lead to not only, bleeding problems in the woman, but also can lead to potentially bleeding problems of the baby.
Of the baby, I should say.
Yeah. And leading to, fatality of the fetus, too.
Okay, so, however, not to scare anybody away from doing this wonderful thing, getting pregnant, I think that now maybe some of these things are not as much of a surprise as they've been in the past, only because of the massive amount of study that's been done by OBGYNs and the natal care, prenatal care, and the GP and the hospital, and everybody's aware of what may be happening or not happening inside that lady.
Right. So yeah, in some of the newer anticoagulants that have been developed over the past 10 years or so, there's a variety that won't cross the placenta and are potentially safe. Again, if you feel like it's needed. So the medication that we usually use in pregnancy is something called low molecular weight heparin. Now, heparin is another blood thinner that I think many people have heard of.
I've heard of that, heparin, yeah.
And low molecular weight heparin is kind of a cousin of heparin, but it's a little safer. When taken, the possibility of maternal bleeding is just 2%. So that's pretty low.
Yeah, unless you're one of the 2%.
Well,
but I agree.
No, and that's exactly the point. 2% is low, but is that still too much of a risk to warrant treating someone? So we have to figure out the risk of DVT, blood clot, has to be a fair bit higher than the risk of complications of one of these medications.
Let me ask you real quickie. Let's say that somebody comes in with symptoms during their pregnancy, and let's say they're at 30 weeks, 35 weeks, whatever, and you've identified, this is going on. The call has yet to be made, and in many cases, aren't you able to wait until baby has been born, and even maybe a little time after, if it is not a serious problem like a clot that looks like it's going to come loose? I'm just asking.
And that's a very good question. Yeah, you would have to kind of consider the anatomy of the clot. Where is it? How big is it? Et cetera, et cetera. There are certainly plenty of clots. Maybe DVT in the lower part of the leg.
I was going to say, if it's in the lower leg, and it's there, can that be on the shelf for a while?
It probably could be. You have to weigh the other. You'd want to monitor that DVT very closely, because the other thing that you don't want it doing is propagating. Getting bigger, which it might. So that would be. So you may want to watch it for a little while, and if it remains stable, then you may be able to get her through those last 5 weeks or whatever.
And by the way, gang, a clot is not that little thing that happens on your thumb, although it is a clot. Some of these things that are inside folks' veins we've seen are covering some real estate. They're rather large.
And typically that's what's going to happen during pregnancy, because, often, as I mentioned before, often those DVTs are occurring in the pelvic veins.
Sure.
And those pelvic veins are big.
Yeah.
And
look what they do. They're pretty big. Yeah.
If the vein is big, then the clot could potentially also be very big. But so low molecular weight heparin is the thing we use. The bleeding risk is low. It can be a little expensive. It can be a little uncomfortable, especially if you've made the decision to treat, a pregnant woman throughout the entire pregnancy, because it's an injection.
I was going to say, a lot of people thought that is an oral medication, but it's by injection.
It's an injection, So it goes into the subcutaneous tissue. Yeah. So often, people give it into the abdominal wall.
Sure.
And you can have a fair amount of bruising and that type of thing. So in any case, we have to be very selective in who we treat. Obviously.
By the way, when you say, it needs to be treated a special way, is it a large amount of fluid, or is it a regular in a regular doctor's needle?
Yeah, just a standard kind of volume.
Yeah, okay.
It's not big. It's not a large amount.
Yeah. In other words, you don't hang there on an IV going on you for a couple hours of that stuff.
No.
Okay.
But as it's given, you have to give it to yourself a couple times a day.
It
gets probably uncomfortable.
Especially if, like Indiana Jones or me, you hate needles. I hate needles.
Yeah.
Okay.
So then you go through the decision making. How high is the risk, and does the risk warrant the risk of taking a medication to prophylactically address that. So the two greatest risk factors that occurred during pregnancy that may lead to or that make you concerned about that woman developing a DVT is a woman who has had a previous
you got
DVT.
A history.
Even
one or more.
Well,
even more,
one, but more. Repeated DVT in the past would make you even more concerned about it. So previous DVT during pregnancy or not, and then again one of these hereditary hypercoagulable states. We call that a thrombophilia. So there's hereditary thrombophilias, and actually those genetically induced hypercoagulable genetic things are a little more common than you might think.
Yeah, and you may remember that we talk about this a lot on the program. That a lot of your venous conditions are inherited. I mean, it's something that's just the way it is. So if you are pregnant or about to become pregnant, or your mom or your grandma, chances are you're going to be exhibiting some of that yourself. Mm-hmm. That's just the way it is.
Right. Yeah. Sure. Yeah. So just in the general population, these hereditary thrombophilias, which is a genetic indicator of increased risk of clotting, it's seen in about 15% of the general population. So that's a pretty fair number.
Sure,
yeah. Now there are some hereditary thrombophilia that are bad, and there are some thrombophilia that are not so bad. Okay. So they kind of have to take that into consideration too. But though a hereditary thrombophilia is going to be present in 50% of women who develop a gestational DVT or PE.
Okay.
So again,
here it comes. If you've done it, here it comes again.
Yeah. So if you, so these are some of the things that, again, a woman who's contemplating pregnancy, especially if it's at a little older age, then you have to take these things into account. Now, she may not even know that she has a hereditary thrombophiliia.
Good point, because I want to know if there are some symptoms that are specific to that, or if they can be like a lot of the other things that we talk about in the program. There's a myriad of symptoms, and you have to by elimination, you have to decide what it was. But I would imagine that some of this would be a little bit more evident, particularly if there was a history of it.
Yeah, well, yes. I mean, that would go without saying. I mean, if a woman had a DVT and she found that because of that DVT, she found out that she had this thrombophilia. Yeah, there's no question. I mean, she's in a high risk bracket. But some women don't know, have no symptoms, have never had a DVT, but they may be carrying this genetic, indicator that they're of higher risk. So the way that since it's a genetically acquired thing, they have to be concerned about their family history.
Sure.
Did their mother have a DVT that wasn't, fully explained, or did their mother have 2 or 3 blood clots, or their father or grandparent or whatever?
Isn't it fascinating, Dr. Juleff? And by the way, Dr. Juleff is the medical director of Vein Clinics of Hawaii at veinclinicsofhawaii.com. I'm so glad that the age that we live in is the one that we are in, because how some of these folks got through things before the rapid transmission of information, the world that we live into now, the medications that we live into now, it's a miracle that we're around.
Oh, yeah. Sure.
Yeah. But still, that doesn't ever mean that you should totally relax your guard and think, well, everybody's going to be taking care of me. It's going to be automatic that I go through this okay.
Yeah. Right.
Okay.
Yeah, well, that's a good point. I mean, we have gotten very used to, for instance, pregnancy and delivery. It has gotten so, I think, uncomplicated, presumably, in this country and in other developed nations that you sort of take it for granted.
Well,
but
isn't there a high mortality rate in some of the third world and some of the places where pregnancies are one thing, but birth is a whole other problem.
Yeah, and that's where we all were, in the past.
It wasn't that long ago.
But medical science has brought us to where we are today, and we sometimes we tend to take it for granted. But there's something called, and this is another name that some people are going to recognize or hear, and that's something called Factor V Leiden mutation. That's one of the thrombophilias that are particularly high risk in pregnancy and also fairly common in the general population. When we talk about 15% of the general population having some form of thrombophilia, Factor V Leiden is at the top with respect to frequency within that group. So, if you know that your mother, these things are often known, and people don't know that it's important for them. Yeah. Mom had it. That's not me, and I've never had a problem. But maybe you have it, and you need to be fully aware of it and discuss it with your caregivers. But Factor V Leiden. There's a prothrombin mutation that is also very common as far as pregnant women that develop DVT, and again, those are all potentially in your family history that you should be aware of.
Okay, now guys, if you're still with us at this point, we appreciate you sticking around. I think that once again, a little tip of the hat goes to these ladies who have so many things to worry about doing this, and I'm guessing also that it would be, if you've not done this before, gals, that you really need to find out as much about your family as possible. Mm-hmm. I mean, I'm guessing that a lot of this stuff wasn't imparted. I mean, it was, maybe nobody knew any better. That hey, if you do get pregnant someday, you may do this, or you may do that. Maybe a lot of times these gals have no clue.
Right, sure.
What a whole bunch of situations that they might have going into that they with doing a little inquisitiveness and some questioning, they could find out about it.
And for instance, somebody's mother or grandmother, they may not know, what the problem was, but maybe they had a history of having, 2 or 3 blood clots on different occasions, and that's something that you need to take note of. So who are the people that we treat? And there's an organization called the American College of Chest Physicians, and they're involved in making recommendations for a lot of different things.
Not just the heart and chest.
But DVT treatment is one of the things that they have outlined pretty specifically. So they are currently recommending prophylaxis, and by that I mean treating a woman with low molecular weight heparin during their pregnancy for those women with a prior DVT and a known thrombophilia. So, those are the two things that elevate the risk even substantially higher above where they are just being pregnant. So if you have had a prior DVT and a known thrombophilia, then you should be indicating this to your physician, and they should be seriously considering anticoagulation during your pregnancy. Those women who have had multiple DVT prior to pregnancy, so whether they have a thrombophilia or not, if you're a woman, you've had 2 or 3 episodes of blood clot, it was never completely defined as to why you had those, or there was no apparent reason, then I think the assumption there is that probably those women are hypercoagulable, they are clotting too easily, and that history with being pregnant probably warrants anticoagulation.
What you said, one of the additional risk factors is that all this being done when you're 25 is different when you're 35.
Oh, yeah.
And I know a lot of this audience are either having children that are still being educated or in college, and they want to get into the world of business or whatnot before they sit down. I think that the generation that we're in, and certainly the next one, are going to be planning babies a little a little more than maybe we did in the past. You know, say que sera, yeah, she's pregnant again. But wait a minute, maybe we don't want that for a certain while.
Sure.
Not economics, just the physicality of mama wants to have a career and she wants to do well, and she doesn't want to have lots and lots of babies.
Yeah, and that's a trend that started a while back, 10, 15, 20 years ago. And I don't think that's going to change. I think that's going to continue. And so it makes it even more, imperative that you have some of these concepts in mind when thinking about becoming pregnant. Mm-hmm. So anyway, so that's that we would treat that patient with low molecular weight heparin throughout their pregnancy and through that post-delivery period, that 6 to 8 week period where they're still hypercoagulable.
I was going to ask you about that because sometimes think birthday, all the problems are gone.
Yeah,
and this beautiful thing is not in me anymore, and he or she is doing just fine, and so am I.
Yeah,
it's a lot of repair work.
Still, recovery. Things are still repairing themselves. Yeah. And then in addition, especially during that postpartum time period, if a woman has had a C-section. Mm-hmm.
Oh yeah, I saw that in the notes before. Let's talk about that because that's a whole other set of circumstances, isn't it? C-sections, and even though I'm certainly today a lot better than they used to be, they still are. There's still risks there.
Well, it's a surgical procedure, and during obviously the termination of the pregnancy or the end of the pregnancy comes, the baby is delivered through a C-section, but that's considered a surgical procedure, and just having gone through that surgical procedure is going to put that woman at a little higher risk of DVT during that postpartum time period.
Very interesting. By the way, the way we can talk about things like C-sections now is totally different from what it used to be. I mean, a man would never know what a C-section is.
Yeah.
Or be able to mentally handle exactly what it is. What causes or what necessitates having the C-section?
Oh, Lord. A lot of different things.
Yeah, I'm sure it could be. But I do know that sometimes just the shape of a woman that is not ready for, maybe there's a large baby or something in other words, the decision is not a rash one.
Yeah.
Or a quick one, is it?
Well, sometimes it has to be.
Well, I mean, in case of a trauma or something.
But sometimes it's it's planned out. But I think sometimes it's planned for one reason or another. Yeah. But I think for the most part, C-sections are done when there's some interruption of the normal delivery process. That may be threatening the child or maybe threatening the mother
or the mother
or both. Yeah, sure. But we how do we diagnose DVT during pregnancy? Well, the same way we do any other time, and that's with an ultrasound. Very quick, easy, non-invasive, no radiation, so that's good. During pregnancy, you're trying to avoid radiation. And that takes care of that I think makes the diagnosis of most DVT, because most DVT is going to be in the lower extremity, or at least be able to be seen in the lower extremity. However, sometimes, again, we keep talking about these pelvic veins. Sometimes that can be the origin of the DVT, and typically it's not easy to see pelvic veins with ultrasound.
Yeah, I was going to ask you about that. And we've talked about that in previous programs about the ultrasound equipment, because I know that it only goes so deep, and aren't some of these veins way inside?
Yeah, right. Yeah. And so if a pregnant woman comes in and there is a very high suspicion that she might have a DVT, because of the symptoms that she's having or whatever, and we do an ultrasound of the lower extremities, we don't see it, then, typically you kind of have to do something else to make the diagnosis, because if there are significant pelvic vein DVT, that woman probably, she does need to be treated.
Okay, let me ask you this real quickly, because I do know that patients get referred to the Vein Clinics of Hawaii in a number of ways. Sometimes it's an OBGYN, sometimes it's a primary care physician, or just your regular general doc, internal medicine guy, and sometimes it might be, another professional practitioner, a dermatologist, all of these different things. So it seems to me that there has to be a high level of communication between all the specialties with a pregnancy.
Oh, yeah.
Yeah, that's pretty interesting.
I mean, if we were to make a diagnosis of a DVT in a pregnant woman, I probably would not feel comfortable actually treating her or prescribing the medication.
Right.
I would certainly want the OB-GYN to be involved and whoever else that might be involved in the care of that lady.
I kind of think it's fascinating, though, that it seems to me that there's a lot less them and us now. I think that in the age that we've gotten to, that our primary care physician or our internal medicine guy knows he's like a quarterback, or he's like doing a decision. Which of the hundreds of different specialties you go to? Well, these are pretty big ones, right?
Yeah.
Your vascular surgeon, your OB-GYN, and your general practitioner, they all have to be on the same page.
Yeah, they all have to be on the same page, and it's good to have a quarterback. The primary care physician has to kind of keep it all organized and keep the interaction going between all the people that are involved in the patient's care, and making sure that the pieces all fit together. So anyway, sometimes if we have to do something that looks at the pelvic circulation, the pelvic veins, then sometimes we have to do a study that is going to, give some amount of radiation. Now, we can do MRI, in that does not have the same type of radiation that you would normally see with a CT scan. Often an MRI can make the diagnosis of pelvic vein.
I've had the fun of having an MRI recently, and I'm going to guess that for some women, having an MRI in pregnancy is pretty tough.
Yeah,
because I know that they're getting a little bit bigger than they used to be. I'm talking not the women. I'm talking about the machines.
Yeah,
but that there still is a claustrophobic factor.
Oh, definitely. Yeah.
I just did that. I couldn't believe it because this guy, the operator said, "Okay, squeeze this if you panic." I'm not going to panic. Come on. And then you think, should I squeeze this thing? But obviously, it's interesting you say that, because if that is indicated, wouldn't it scare some people off? Oh, this is a big, long X-ray. I don't want that.
Mm-hmm. Yeah. So, in some situations, a CT scan might need to be done. Yeah. Now, CT scan does give you radiation, and, there's ways to protect the baby if the woman really needs it. There's a time period that the fetus is most sensitive to radiation. Usually that's around 8 to 15 weeks. You try to take every precautionary measure that you can if you need to use a CT scan to make that diagnosis.
Do you recommend that your regular patients, somebody that gets pregnant and has a baby, do you recommend, even if they were on a treatment plan, that to be very patient about when to start doing the surgery after recovery, after she's had the baby?
Yeah, just in general.
Yeah,
you mean?
Just in general.
From a general standpoint, if women develop venous problems other than DVT, when do we treat them? We don't do it immediately, because the one question there is that often if a woman has developed varicose veins or swelling and other symptoms having to do with potential vein disease, much of that often a lot of that will recede.
Gotcha.
So she may recover, and 2 or 3 months later she isn't even feeling like she needs to have anything done.
That's pretty cool. I mean, and I do know that sometimes especially when you talk about multiple pregnancies, if you have venous conditions, they are likely to increase. Oh, yeah. Because of these multiple pregnancies.
Yeah, exactly.
And that you're going to be sort of waiting a while to get treatment. Okay, now that being said, obviously we don't want to discourage anybody from having a baby and doing their life.
No.
And I think, guys, if you've made it through the show, I hope you've learned plenty. And if you want to learn plenty more, not just about this, but about anything, you go to VeinClinicsOfHawaii.com and you get help. But I think this is a real important juncture that people make, that they learn that having a baby, there's a team of people that you really need in this day and age.
Yeah, definitely.
Yeah, pretty interesting.
Yeah.
Okay. Anyway, that's gonna do it for this time. We're so glad you could join us. I do want to remind you to make an appointment at the Vein Clinics of Hawaii. Go online and check it out. VeinClinicsOfHawaii.com. Dr. Julep and the staffs are on the Big Island, on Maui, on Kauai, and right here on Oahu, and that's where we are doing the show. So have a great rest of your day. See you again next time. And guys, if you made it through this, you get a gold star in your chart, and you can go play around the golf, or who knows, maybe even go fishing. Thanks for listening. For Dr. Julep and the staff, I'm Mike Buck. We'll see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, VeinClinicsOfHawaii.com. That's VeinClinicsOfHawaii.com.